Hi, and thanks for joining today's Provident Coding webinar series. Today we'll be talking about 2017 ICD-10 DRG audit target areas. I'm Ben Saverborn, a manager at Provident Consulting. I've experience in ICD-10 services, post-ICD-10 compliance, and many audits since ICD-10 was implemented. We'll be going over case studies with sepsis, excisional debridement, COPD and asthma exacerbation, and COPD exacerbation with pneumonia. All right, let's look at our first case study. So we have a 73-year-old male with a history of diabetes, bladder cancer, status post-nephrectomy, and has a history of hydronephrosis, status post-nephrostomy that was removed about a month ago. He was treated with Levaquin for a UTI, but he did not get any better and he presented to the hospital. He was diagnosed with AKI due to hydronephrosis with a question of UTI, was started on antibiotics and admitted for further evaluation. Both urine and blood cultures were found to be growing Candida, so he was switched from Zosyn to fluconazole IV. ID diagnosis was acute cystitis with sepsis, secondary to acute cystitis with hematuria. Final diagnosis was sepsis, secondary to acute pyelonephritis and Candida. So this is actually based off a real case, and the coder originally went with sepsis of unspecified organism, and then had a secondary diagnosis of other urogenital candidiasis. So they didn't use the combination code for candidal sepsis, which is what we recommend. So by using the combination code in ICD-10, it actually shifts the DRG from 872 to 871. So it's very important with the new ICD-10 DRG methodology that using the combination code actually shifts the DRG with just one code. So some of the other considerations. So this patient comes in with sepsis secondary pyelonephritis. So because they use those two codes of the sepsis and the urinary candidiasis, referring to the candidal pyelonephritis, that actually puts it into a DRG of 872. So the physician actually linked the sepsis and the candida. So a single code, B37.7, should be assigned. Candidal sepsis is designated as what is called a principal diagnosis is its own MCC for MSDRGs. Revising the principal diagnosis shifts the DRG from 872 to 871. So for patients with sepsis, it's not that common, but it's something that should be looked at for really sick patients. So look to see if they're treating with fluconazole or diflucan, which is this could offer a clue into the type of sepsis the patient has. So if you ever see a patient with sepsis and they're being treated with an antifungal, then consider looking for documentation that this patient might have sepsis due to candida, and you can see by the treatment. Other sepsis that also acts as their own MCC are anthrax sepsis, the second one, which I cannot pronounce and I've never seen before, listerial sepsis, and gonococcal sepsis. You know, the reason why they're MCCs is because they're not that common. So probably the most common is the candidal sepsis out of the group. So that's the one you want to look for. And of course, severe sepsis and septic shock, that automatically takes you to DRG 871. So looking at our second case study, we have a 66-year-old female with extensive history, presents at the ED with foul-smelling stage 4 sacral decubitus ulcer. White count was elevated to 28.4. She was started on IV antibiotics. She was seen by a plastic surgery service and was noted to have noticing the prognosis notes to have sacral pressure sore cleansed, necrotic tissue excised, and sent for cultures. So the original coding, the coder went with pressure ulcer of sacral ulcer, stage 4. It's a DRG of 592. They did not see that the patient actually had an excisional debridement, so adding those codes would shift it to a surgical DRG of 579. All right, so just looking at the specifics here. So the original coding was the coder went with, they did not code the excisional debridement. So the reason they may have overlooked it because the surgeon only documented that the tissue was excised. They didn't say they had an excisional debridement specifically, but just documentation of an excision of tissue is sufficient to use the root operation, the PCS root operation of excision. So it's important to always look through the entire medical record. It's sometimes you're just looking for that op report, and of course, if it's there, you probably won't miss it in that if they if the surgeon performed a excisional debridement. However, if it's in the progress notes, it could be a very short note, but that short note can make a very big difference. And also, just interesting, just in a recent coding clinic, that if the body part, if the patient has a sacral ulcer, then ICD-10 actually assumes that you code both left and right bilateral for just a sacral region ulcer. So that's interesting because most likely because sacral ulcers, they're on the lower back, they can kind of be on the left and right side. So it makes sense that ICD-10 would assume that a sacral ulcer would be both left and right. The guidance actually is to code left and right hip muscles. Because all that was written was that there was an excision of the sacral pressure ulcer. So two codes are needed. So what's also interesting too is if the patient has a principal diagnosis of a stage 3 or 4 pressure ulcer, this just like septic shock will automatically put you in a DRG with an MCC. So any patient presenting for a stage 3 or 4 pressure ulcer automatically goes to the DRG with MCC. However, stage 1 and 2 doesn't impact the DRG. So let's move on to a very short case, but it's an interesting one. So a patient presents to the hospital with COPD exacerbation and an asthma exacerbation. So in ICD-9, this would just be a single combination code of the original code of 493.22, and that would take you to DRG 192, COPD without CC or MCC. However, in ICD-10, the guidance is to say that if a patient comes in with COPD and asthma exacerbation, two separate codes are used. So you would code J44.1 and J45.901. So this would put you in DRG 191. So just make sure that if a patient comes in with COPD and an asthma exacerbation, there are actually two codes that are needed, and you get a CC with that. And this just summarizes what I just said. Looking at the ICD-10 index instructional notes, it tells you that you need if a patient comes in with COPD and also has an asthma exacerbation, you code asthma separately. Code also the asthma. And if it's an exacerbation, then it would be a CC. It's not excluded. Now let's move over to our final case study of COPD exacerbation with pneumonia. So we have a patient presenting, he's a 65-year-old smoker, presented to the ED with severe respiratory distress, requiring BiPAP, diagnosed with COPD exacerbation, respiratory acidosis, and pneumonia likely due to MRSA. ABGs on admission has a pH of 7.23. So the original DRG option would be COPD exacerbation and secondary code of COPD with acute lower respiratory infection, and then coding pneumonia as an MCC. Take you to DRG 190. This is because of the sequencing rule that is very controversial. You must code COPD as principal and pneumonia as secondary, no matter what the reason the patient was admitted. It's very controversial because I think most people disagree with that. And one of the strategies here is to query for acute respiratory failure based on the clinical evidence presented, and there would be a slight increase if acute respiratory failure was documented. So DRG would shift from 190 to 189. So very important that as of right at this moment, COPD exacerbation and pneumonia, totally different coding between ICD-9 and 10. In ICD-10, the coding rules, the actual guidance in the book, says you have to go with COPD exacerbation even if it's not even if it's an exacerbation. So if a patient comes in with the COPD and pneumonia, and the COPD is not even exacerbation, then you still have to go with COPD as principal. That doesn't make any sense following traditional or foundational coding knowledge, that you should code the reason for admission after the reason for admission. So if a patient comes in with COPD and pneumonia, the reason for admission is pneumonia. So in most circumstances, so it makes no sense to have to go with COPD as principal. But as of this recording, which is in April, based on the ICD-10 coordination and maintenance meeting minutes from March of last month, there's actually discussions to change this. This is too controversial. It goes against all coding logic, so I would hope that this goes through and that we can revert back that the sequencing should be the discretion of the coder. Or if a patient comes in with COPD, exacerbation, and pneumonia, the coder really should pick, and typically I would say the pneumonia would be the more acute condition. But of course there are exceptions if the COPD exacerbation is so severe that that is the reason for admission. As of right now, that's overruled. So let's see if that does change. So thanks for joining today and listening in. We'll be releasing more findings on our website, providentedge.com. If you have any questions, here's my contact information. It's bsayavorn@providentedge.com. Again, thanks for joining. And please check our website if you have additional questions or would like to contact us. Thanks.